So in this video, we're going to talk about MRI of the epilepsy patient. When is it indicated? What will you get out of it? Managing the client's expectations and what they will get out of it, and also what protocol you should use. So in this video, we're going to discuss the pros and cons of obtaining a brain MRI on a pet with epilepsy. Epilepsy is defined as having recurrent seizures, which is usually taken to mean having 2 seizures or more with a space of normality in between those seizures. And there are many motivations for getting an MRI scan. All owners tend to want the best for that animal. And even if they are comprehensively insured or have a large amount of funds available, it still has to be considered for each animal what is the best investment of that funds and what the client, caregiver and pet are going to get out of having that MRI. So why MRI at all? I'm often heard it referred to as the gold standard, but actually it isn't a gold standard at all, because a gold standard would give us far more information. It is probably the best test that we have for gaining the most information about the brain and why you would have epilepsy. But it's not giving us as much information about the cause of the epilepsy as we much like. For example, it's a structural imaging. It shows the structure of the brain. It doesn't show the function of the brain and the electricity or abnormal circuits that might be going on in there. It doesn't give us information about chemicals. That would be spectroscopy, which is done in some human patients. It doesn't tell us about nerve cell activity. That would be an EEG. And in human epilepsy, EEG is a very, very important investigation. But it's much more challenging to do in pets, mainly because they may need sedation, which will suppress the activity. And the most important reason being is that the EEG is most valuable when the animal is actually having an event. In humans, they will admit you to an epilepsy ward. They will stick you in a bed, stick an EEG on you, which has got a lot more electrodes in it than we can have for dogs, and that's because humans have a greater surface area on their head. They will stick a video on you, and they will record you, and they will do things to make the seizures more likely, like take away your medication or sleep deprive you. And these are just things that we can't do in dogs for ethical reasons, amongst other things, and also for practical reasons, like they won't just sit in a bed with a video trained on them with a little mop cap on of electrodes. Often in dogs, we have to use needle electrodes because the surface electrodes don't make good enough contact because of the hair or all of the muscle underneath. And it's not a genetic test. So I sometimes get caregivers wanting to have an MRI scan of their dog to prove or disprove that the dog has got an inherited cause of epilepsy. This is particularly important for those that perhaps might want to breed from a dog that's had 1 seizure, but it doesn't tell us that. So this is one example of a dog with an inherited disease that was causing seizures. This is L2 hydroxyglutaric aciduria. And this is much, much cheaper to diagnose by a DNA test, just about £40, $40, a saliva swab or a blood test, compared to thousands of dollars, pounds for an MRI scan, which was obtained in this case and shows the cytotoxic edema right through the grey matter in this dog that's due to this metabolic acidosis. So this is all this white area here through the thalamus and through the grey matter, and then through the grey matter of the cerebellum, and also in the grey matter of the spinal cord. This has to be confirmed by the DNA test or urine organic acid. Another example, this was a dog who was referred to me. It was a basset hound, and I did a blood test on him and genetically confirmed that he had Lafour's disease, which is a progressive myoclonic epilepsy. However, he had been previously diagnosed by a very well-known specialist veterinary neurology clinic as having idiopathic epilepsy, and they made this diagnosis on the basis of a normal MRI. This is not his brain, but it's just to show a brain of a dog with Lefort's disease. This is a neuron here, and this is the typical glycogen storage, polyglucagon storage material in the hippocampus. And it's this storage material here and here, which causes irritability and the myoclonus and the seizures. This was an older dog when he had the MRI scan. And in knowing that this disease was a differential, and doing a cheap genetic test would have been a much more useful diagnostic test. It's impossible to keep up with all of the diseases, but I would compel all people who are offering an MRI scan that it is always worth doing a Google search for different breeds that you're not so familiar with, just to see if there is any inherited diseases coming up. It's also very important to manage people's expectations, both referring vets in my case and caregivers. So take the example, the hypothetical example of Billy, the 4-year-old golden retriever. He has a 2-year history of refractory epilepsy. So it means the seizures have been occurring for 2 years and they've responded poorly for the drugs. And so hypothetically, we imagine that Billy's vet has referred Billy to me for an MRI scan, and I'm seeing Billy's caregiver. Now, it's not unreasonable that Billy's caregiver or the primary vet may expect the MRI to give some pretty definitive answers. They may expect to give a diagnosis and answer why the seizures aren't controlled. They may expect to give a definitive answer on the treat, perhaps treat with wonder drug A and everything will be all right. Or I had some vets tell me that when they refer the dog, they expect me to either cure it or find something really awful with it and euthanize it so that it was no longer a problem to them, which is rather harsh, and not a very minority number of vets would ever think that, but I was told that by somebody once. Now, I've put these little bright colors in here, and these don't exist. So the reality is that when you do an MRI scan of a dog with breed-related idiopathic epilepsy, there are no structural abnormalities. So no magic little signs that are going to tell us what drugs to treat, that the disease is inherited, or nothing that will tell us actually the prognosis and whether or not we will be able to find a treatment. So idiopathic epilepsy is a diagnosis as a rule out by saying, well, there isn't anything else that we can see here. And it doesn't tell us what drug to use. It doesn't tell us whether the pet will respond to the drug. And another point is that if the dog has previously had a normal MRI and a diagnosis of idiopathic epilepsy, they're making an emergency referral for a repeat MRI because the dog's having lots of seizures isn't going to be useful. And it would be better for the caregiver to spend money on a consultation with an expert to treat the seizures. So if they already have a diagnosis of idiopathic epilepsy, having another MRI doesn't give us more information. And very importantly, the MRI doesn't do what we would really like us to do and tell us if the animal is actually having seizures. And we're increasingly aware with the arrival of the mobile phone that dogs can have a lot of episodes of things that can look like seizures. For example, this is the footage of some French bulldogs that were sent to me. 2 different French bulldogs, all doing this weird twisting action of going round and round and round. Looks pretty similar in both of these dogs. And the question was, is this a seizure? And would an MRI help tell us this? Leaving a pause because I'm having you have a chance to think about it. Do you think MRI would help in this instance? Some of you will get the answer. No, because this is a problem with the tail. This is screw tail or tail fold intertrigo, which means that these dogs, French bulldogs and English bulldogs that have these twisted tails, often inverted into their body, and they have a fold of skin that is all moist because it's not exposed to the air, and normal skin secretions are secreted into this sort of moist warm environment. they get bacterial infection, and it becomes very itchy and irritated. And unlike idiopathic epilepsy or a movement disorder, this actually can be completely cured by surgery. Surgical removal of the tail folds or amputation of the tail. So it should be done by an expert, because you can also have many complications as a result of that, but potentially for cure. So the MRI is not telling us whether or not that animal is having a paroxysmal brain event, and in some cases actually may be wholly inappropriate. So why does a vet recommend an MRI? Most of the time it's to rule in or out structural disease. So this is an MRI scan of a brain tumor, specifically a meningioma. So we can see the brain tumor here, and it's pressing the brain in from the outside, from the meninges, and it's causing a lot of secondary edema here, and the edema and the secondary effects of the tumor are resulting in seizures. Some may recommend it because it's good science. If we want to make the most diagnosis that we can, then we should do an MRI scan, because it takes us to the level of being able to what we call a tier 2 confidence level for the diagnosis of idiopathic epilepsy. And we're going to talk about that in more details. It may be because it's insured. People pay a lot for their dog insurance, and they do so that they can have the opportunity to have expensive diagnostic tests, so that they can have the best diagnosis for their dog and therefore the optimal treatment, especially if the dog is having many, many seizures. A vet may be recommending it because they have an MRI machine, which is fair enough. I mean, if this is an extensive resource, it's expensive to maintain. And having a diagnosis of epilepsy would be a very important part of that MRI scan's throughput. And it may be because the primary care vet or the caregiver thinks this is essential before starting treatment. This is debatable, depends on some other things which we're going to be talking about. But certainly it can help you refine treatment and know that you are correct to start anti-epilepsy drugs as opposed to some other kind of treatment. And it may give the owner reassurance that there's nothing else going on. And that's incredibly important to know that you are treating an idiopathic epilepsy rather than a brain tumor. So when we're looking at causes of seizures, this is often a diagram that I will try and draw out for my owners. We can roughly divide them into extracranial or reactive causes, which you can loosely describe as things going wrong in the blood going to the brain, or things going wrong in the brain. And these should all be worked up first. And so it would be usual for hematology and serum biochemistry to be taken to rule out these sorts of problems here. Toxins, well, animals that have been exposed to toxins are often presenting in status epilepticus, and in there it would be appropriate to take urine toxicology for recreational drugs, illegal drugs, that sort of thing. I must admit, I use urine dipsticks in this regard. These are the dipsticks that are sold in chemists for workplace urine testing of humans. I like them in the emergency room setting because you get a quick answer and they're cheaper. It takes a few weeks to have analysis come back from urine samples otherwise. Obviously, we can do genetic testing if the dog is an appropriate breed. And so then we get to ruling out the structural epilepsy. And by far the most important test is actually your neurological exam. Never use an MRI scan to bypass a neurological exam. And what do I mean by that? Well, we diagnose idiopathic epilepsy on the basis of 3 tiers. Tier 1 is having 2 unprovoked epileptic seizures at least 24 hours apart, being between 6 months and 6 years, having an unremarkable neurological examination, and having unremarkable minimum blood tests, and urinalysis is often put in there as well, but that's not always done. So what this is basically saying is if your dog is between a certain age, and certainly if they're between if they're certain breeds, and they have recurrent seizures and their neurological examination remains normal, then there is a high chance that they have idiopathic epilepsy. And not all dogs have to have an MRI scan. We can say that they have an idiopathic epilepsy with tier 1 confidence. On the putting it another way, if an animal has a progressive brain disease, then the neurological examination changes in some way. And so repeated neurological examination should not be underestimated, and is a very reasonable way of making a diagnosis in idiopathic epilepsy. Tier 2 is all the factors listed in Tier 1, doing dynamic bile acids to rule out a liver shunt, and then brain MRI. In the official guidelines, CSF analysis is included in that. However, many neurologists will not do CSF analysis on the basis that if the brain MRI is normal, then the chances of this being abnormal are very low. And tier 3 is actually aspirational because, as I've said before, doing an EEG, electroencephalogram, during an event is much more challenging. And in the interictal period, it's not necessarily informative. So this is really having an EEG diagnosis. So put another way, our diagnostic approach to epilepsy is first to try to find videos of the episodes, because there are other paroxysmal episodes out there, movement disorders, paroxysmal dyskinesia being one example. Clinical and neurological examination, blood tests and urinalysis, and then you rule out your intracranial causes by repeat neurological examination, and then in some cases MRI. And depending on what other things that you find, then you may be doing all of these tests as well. So, should you do an MRI or not? Well, the advantage is that it rules out the nasties, things like brain tumours. And in some instances where there are nasties, it can help with decision making for treatment. The disadvantage is it's expensive. It's not a specific test for inherited epilepsy, so I can't prove that the dog has inherited or breed-related epilepsy. I can just say that it's idiopathic, most likely breed-related. It doesn't help with the prognosis or treatment, and of course it requires a general anaesthetic, although nowadays it should be possible to perform that safely. I also want to point out that not all MRI or vets offering MRI are equal, and the cost is not equivalent to quality. And that's because there's varying different types of MRI scanner, and there's varying amount of expertise doing the MRI scan. So here's an example of imaging of where it did make a difference. So this is a 10-year-old female spayed border collie. So it's a breed that gets idiopathic epilepsy, but it's not the age. So it's out with that 6 months to 6 years. And so already this would already be put in a category of would be better to do an MRI scan. It has a 1-year history of epilepsy, increasing frequency, and these seizures are focal with secondary generalization. There'll be another video that will sort of go into different seizure types. Needless to say, this means it comes from one area. So it started with a little bit of motor activity and then went to a full generalized tonic-clonic seizures. So it seemed like it was spreading from a focus. And also the dog would have seizures with stress, which is a little bit unusual. Many dogs with idiopathic epilepsy will have seizures from sleep. It was also unusually sedated on even a low dose of anti-epilepsy drug. That's what AED stands for. And it had a recent behavioural change. So this would count as not having a normal neurological examination. So did an MRI scan and it showed a brain tumour. It's difficult to know what sort of brain tumour this is exactly. I think it's probably a meningioma on the basis that the bone is thickened here and this is base wide, but it may be a low-grade glioma as well, especially since it's cystic. So you can see the wall of the tumour here, and the white and the black correspondingly are cystic fluid within it. So with this dog, I altered the medication. I gave it a low dose of prednisolone, which is a steroid which reduces the inflammation. You can see the edema here, and the irritability of the tumour. I changed her dose of bromide and phenobarbital, reduced that because she was very sedated, and I added a drug called levetiracetam, which is a drug licensed for human focal seizures and is very useful for stopping a seizure generalizing. So stopping that focal seizure, stopping it generalizing. And I also gave a drug called propentafilene, which has some mild anti-epilepsy function. It's also neuroprotective. And the dog's demeanor improved a lot. The owners were extremely happy by this because she now had a good quality of life, and she survived a further 3 months before the owners made a decision to euthanize. So, going back to whether or not we should MRI or not MRI, these are the features of idiopathic epilepsy. But if we have these three things, recurrent seizures, normal in-between seizures, which is what interictal means, and age between 6 months and 6 years, then if we do an MRI, and even on a low-field MRI scanner, then 97% of them will be diagnosed with idiopathic epilepsy, i.e. the MRI is structurally normal. Put it another way, if you have a dog with this, there's probably less than there is less than a 3% chance of having something else being the cause of the epilepsy, as opposed to having breed-related idiopathic epilepsy or unknown idiopathic epilepsy. So this means that having a diagnosis with tier 1 confidence is really quite acceptable in many cases. However, it is nice to rule out that 3% because it may change things. So what should a vet offering MRI aim for? Well, they need to be able to rule out structural disease. And I would compel vets listening to this talk to report their MRI scans as having no structural problem, if that's the case, of course, rather than saying the MRI is normal. I think language matters. And when you say the MRI is normal, and the dog is so obviously not normal because they're having seizures, then in many instances you confuse the owner. And I've seen on Facebook forums, other social media forums, owners saying, well, the vet did an MRI scan and doesn't know what's wrong with the dog. And also use your language carefully when you're saying idiopathic. That doesn't mean you don't know what's wrong. That means it's a recognized syndrome where there is no structural abnormalities, a recognized syndrome of epilepsy, in this instance, with no brain structural abnormalities. It doesn't mean that we don't know what the cause is. It is true that we can only guess at the cause of epilepsy, but when you've done an MRI scan, it does mean you've ruled out a lot. So you are not quite in the dark. So I would compel you to report it saying there are no gross structural problems that account for the epilepsies, rather than saying it is normal. In humans, they will say the MRI is negative. And I want to ask you can you be sure that you're detecting subtle lesions? Are you able, is your MRI scan being set up for getting as good anatomical lesions as possible? I have seen some people who are doing a brain MRI for epilepsy, kind of taking shortcuts, and basically all they're doing is ruling out a brain tumor. Doing a few simple images and then giving contrast to say, no, I can't see a brain tumor. Is ruling out a brain tumor really good enough? And this image is being up during the whole time I'm talking, so I'm going to ask you, if you were a vet offering MRI, have you spotted the abnormality in this dog? Congratulations if you have. I'm impressed. So this dog is missing half of its corpus callosum. See? The caudal part here is hypoplastic, and this may be an abnormal kind of bit of white matter going off up here. This is corpus callosal hypoplasia. So no, when you do an MRI scan, you should be very carefully looking at the structure of all of the brain, not just ruling out a tumor or inflammatory diseases. Because this dog will always have a poorer control of his epilepsy potentially, and we may want to use different drugs. We also have to consider what's a good MRI. I said before that they're not all created equal, and this is because they're affected by all of these different things. So they're affected by the protocol, what the slice thickness is. So a high Tesla MRI could get slices down to 1 millimeter. You're not going to miss much if it's a 1 millimeter slice. However, if the MRI scan is taking 6 millimeter slices, and that's quite a big gap in between. It's affected by the sequence. It's affected by whether you're using a low field, which is 0.2 Tesla, for example, versus a high field. The most typical high field is 1.5, but many people are working with 3 Tesla machines. The coil, which is the receiving part of the MRI scanner. The operator. Is it just somebody that's a technician that you've just trained to push a button? Or is it a fully trained radiographer who's done many years working, understanding the physics of MRI, and is really able to get the best out of that machine? Who's interpreting it? Is it somebody who is with a lot of experience, or is it somebody who has not got any qualifications in that regard? The patient, it can be very challenging to get good MRI images of very, very tiny patients, as I'll show you in a moment. And the economics. So these are comparing 2 images between a low field and a high field. This is the best that machine could get for a flare. I took this image. I used to have use a 0.2 Tesla machine. I used to be incredibly patient. So this image would take me about 7 to 9 minutes to obtain, and this is the best it could do. And we can see this in a golden retriever. We can see this area of high signal. It's most likely a post-ictal change. We can see it's a pretty quality flare. This is probably dilated ventricle in here. It hasn't completely suppressed the CSF. So normally on a flare, what you're seeing is it's a highly T2 weighted image. And so white is fluid or fat, is the fat in the bone marrow. And it shows you where you have fluid within the cells, static fluid within the cells. So this is representative of edema, but we can't be sure that it's not a tumor in this instance or inflammation. And a hallmark of flare is it kind of looks like a T2 weighted image, maybe a bit more fuzzy. And then the CSF is suppressed out, so it's black, but this hasn't successfully suppressed that. Compare it to a 1.5 Tesla. Look at this beautiful image. We can see the CSF is black. We can see that there is some slight change around the ventricles there that might suggest edema. We can see that there is a very symmetrical edematous change right through the cingulate gyrus, and we can also see this change in the mesotemporal lobe. There was just a suggestion of that in this dog, and this is very characteristic of post-ictal changes in this particular dog, except for perhaps this possible enhancement around the ventricles. And this image would have taken about 4 minutes to obtain, and so even being very patient with this, it takes a long time to get not as good image as here, and we'll never get over that with that particular type of machine. And so, but this machine, it costs a lot less to run, and was economical in my very small London clinic, where you couldn't have possibly got the helium in for this sort of scanner. So it came down to economics in that point of view. You also have to say, is doing the imaging, doing different sequences relevant? And that's where I'm going to end this particular lecture, because our next lecture in this series is going to talk about MRI of the epilepsy patient, and in particular an epilepsy specific MRI protocol, which is what I would recommend. Thank you very much.